There you
All
go.
right. Okay. So we're good to go. All right. Welcome, everyone. My name is Shikha Kothari. I am a advisor to the Young Jain Professionals, and I have a healthcare background. I'm particularly excited that we're hosting a panel with three different physicians who all went into unique pathways of their own. And you'll get to hear some really exciting stuff from them. Um, just to start up, Young Jain Professionals is a nonprofit organization housed under JAINA, which is the Jain Association of Indians in North America. It's a 501(c) nonprofit. YJP caters to the age range of 24 to 42 years. So it's an interesting age range where everyone's kind of exploring their own professional and personal career pathways. With that, I'd love to introduce our panelists. So we have Dr. Sachin Jain, who is CEO of Scan Health Plan. We have Dr. Samir Shah, who is the co-founder, who's the founder of Cure.ai. And then we have Dr. Chinar Sanghvi, who is a associate clinical professor and an associate program director, interventional pain management physician. Would I say that I've introduced you guys okay?
Sure. Except
Awesome.
I'm not the founder, so
You're not the founder? All
no.
right. All right. Maybe let's start with you. Why don't you talk about what do you call it? Cure.ai and like what was like how did you transition from radiology into working in this space?
Absolutely. So I can do it in like 2 minutes or 5 minutes, like however long. Why don't I just go? And
Yeah.
so I'm in Pittsburgh, Pennsylvania. I was raised, like many of you on the call, I bet, in northern New Jersey, and uh, went to med school, one of the combined programs. I was like very, very typical Indian kid from New Jersey, and went into radiology. Um, Private practice initially in Pittsburgh. My wife's from Pittsburgh, and that's how I ended up here. Everything was totally typical about my story. And about 5 years into practice, my group went bankrupt. And that's partly because this was around 2005. And that's when UPMC in Pittsburgh became this giant, big health system. And basically, a couple of our private groups, we stood no chance and went under. And so I didn't know what to do at the time. And my friend from residency, he was in Australia, and I didn't even know what he was doing. So I called him up, and I was like telling him my sob story. It was a tough time. We had just bought the house that I'm in right now, 20 something years ago. My wife was pregnant with my second kid. My father-in-law was dying in the ICU over a long period. It was like a really, really tough time. I couldn't leave Pittsburgh and I didn't know what to do. And so my friend who was in Australia, he was doing something called teleradiology. And, I didn't even know what that was. And he's like, you should join this practice. It's going to boom, I promise. And I'm like, I was so silly. I didn't even understand. I was like, wait, I can't move to Australia and I can't do procedures in Pittsburgh. And, basically he's like, no, you're going to read from home. And so that's what I did. And I was practicing at UPMC at the same time, interventional radiology. And IR was tough. I'd be there at 6:30 in the morning, and Sachin probably knows this. We were there till 10 p.m. Doing all sorts of things on call and tough. And my wife, who is the proper Jane, like literally looked at me and she's like, "You read from home in your pajamas and do a shift work, and after your shift's over, you're done. And then half the time when you're doing IR, you're never home, you're on call, you're stressed out, you wake up at 2 a.m., you have to go to the hospital, and you make the same amount." And she's like, you should definitely stick to Telerad. And so I went full time with Telly, and then by 2009 or so, um, everything and everyone in Australia, after the financial crash, especially, the tax laws changed in Australia, and all these American rats had to pay taxes in two countries. The financial crash was tough to begin with, And then after spending some time away, all of us like really wanted to be in the US. And I was already here. I was the first one in the US. I was the only one in the US. And that's how I went into leadership. So I became medical director of the practice. And I had no IT background. I'll tell you the very truth. The This was early, Sachin, as you know, Nighthawk Radiology, and it was all owned by private equity in Menlo Park. They didn't even call it private equity back then. It was so far ago. But they saw my name and they saw that I had a public policy degree from Carnegie Mellon. That was like my foray into leadership. It was a master's in medical management. But they saw I had a degree from Carnegie Mellon and I was Indian, so they thought I was an IT guru. And so they put me in charge of IT, sales, all this stuff. And so my journey into leadership is, and this is a lesson for everybody, sometimes you back into things and you get lucky and you figure things out on your own. So I spent the next 17 years in different radiology practices. Teleradiology became corporate radiology, became, large groups of radiologists. I spent a lot of time at Rad Partners where I met Sachin, and that's where, we were eventually 4,000 radiologists. So very, very large. And I'll just tell the tail end again is that over the last 5, 6 years, I started to implement AI into these large RAD practices because tele was usually the first practice that would start using AI. And I learned how to implement it, but then when I became chief of a RAD group, I had to actually acquire it, had to deal with the IT issues, the admin issues, the radiology issues, and kind of became much more expert in it. Even though I have no informatics background, I am actually terrible with tech, and became chief medical officer of an existing AI company. So I wasn't the co-founder, but we were one of India's biggest startups. Today we have about 450 employees. We are live in 5,000 sites. So that across the world, we're the only AI company that has in healthcare that has 400 sites in Nigeria. We're all through Africa. We're the most deployed AI in Africa, most
Oh,
deployed in Asia, most deployed in the UK, but they never had anything in the US. They tried multiple times to get into the US, just to tell you how difficult the US healthcare system is. So the company hired a radiologist, and we also hired like an American chief commercial officer. And I'll tell you, me being Indian background was very good for this Indian company. Um, our claim to fame is really, really easy to say. We hire the top 10% of the class from IIT, so India Institute of Technology. Boom, there it is. So we have 150 engineers when most AI companies in healthcare and radiology our size can afford 5 or 6 because they're really expensive here, not so much in India. We take advantage of the financial arbitrage. And so it's been almost 3 years, and now we're live in about 10 US health systems. So that's about 50, 60 hospitals, going live in another 20 systems. And that's going to be, well over 150 hospitals by the end of 2026. So it's been fun. And I'm happy to answer any questions about it. No, AI is not taking over radiology tomorrow. So nobody needs to worry about that.
Awesome. Well, it was really, really cool to hear this journey of yours. Um, I think maybe I'll move over to Dr. Jain. I know that you moved into a unique space. So you worked with Caremore Health, you've worked with the Obama administration, you've worked with, and then you had like Scan Health Plan. Maybe talk about that journey. I think it'd be super interesting to
sure.
hear.
Yeah, well, thank you so much. It's really wonderful to be here, and it's great to have this forum. I grew up like Samir in northern New Jersey, Bergen County, for those of you who know the geography. And my father was a pain management physician, actually one of the first interventional pain management physicians who gave me two choices when I was growing up. I could either be a physician or I could be a doctor. And it was a very, very, very tough choice. But I chose physician at the end of the day. But like a lot of us, I think we're trying to make our careers our own while also honoring our histories and honoring the goals and wishes of our parents. And I was always naturally drawn towards public policy, larger societal change, and actually went to Harvard and did a government major before going to medical school there. Ended up doing business school between my third and fourth year of medical school before a lot of people were doing joint degrees. And then ended up doing my internal medicine residency at the Brigham Women's Hospital. um, Actually took a leave from residency to go to Washington to work in the Obama administration. Worked in two different roles there. One at the Office of the National Coordinator for Health Information Technology. Two, was part of the founding team at the Centers for Medicare and Medicaid Innovation. So had a really, really rich experience there. Interesting story. My mom actually made my residency program director write me and her a letter saying that he would take me back to residency if, when I was done with my time in government. So got that letter, went back to residency, and then, had to figure out what I was going to do with the rest of my life. And I think, there's a linearity to our careers in medicine where, you do med school and you do residency and you do fellowship, and then you get a job as an attending, and it's quite straightforward. If you're having a non-traditional career in healthcare, it's the opposite of straightforward. And you actually have to have a lot of comfort with ambiguity. You have to take a lot of chances, take some risks. And very strange thing happened to me coming out of residency which was I got a call from Merck, the global pharmaceutical company, asking if I wanted to be their chief medical information and innovation officer, a role I had no idea what the expectations were for, but sounded interesting. There was an incredible boss that I got to work with there, a guy named Mike Rosenblatt. Went there and spent several years at Merck. I got my PhD there, which was a PhD in passive aggression. It was a really tough and complicated environment, and I didn't make it easier myself. I was a 31-year-old vice president, and it was a complicated time and a complicated environment. Um, that honestly, to Samir's point, we have to be vulnerable about didn't was not a super successful period of my career, and I found myself, trying to figure out what I was going to do next when my time had really run out at Merck. And I got a phone call from, one of the real icons in managed care, a woman named Liba Lesson, who had founded and scaled this company, Caremore. And she was looking for someone to be the chief medical officer. And we just happened to have a friend in common. And I think that's another point here, which is a lot of careers are just really happenstance. And you have to lean into that happenstance, and you have to lean into the kind of unpredictable moments in your career. And I got a call from Liba, and she said, would you ever think of moving to California? I said, not really. I'm like an East Coast person. But as I kind of learned more about the opportunity, the organization, and what she was really looking for, which was a successor to her as the CEO of the organization, I said, why not? And I'll never forget this conversation with my father. I was very stressed about moving to the West Coast, and I'd been an East Coast person my whole life. And I said, Dad, how did you kind of leave everything that you knew, move to a country that was completely um, unknown to you, and establish a life here? And he said, Son, you sometimes have to turn your heart to stone. It was a beautiful expression, and also, kind of, I think what really characterized the journeys of all of our parents, and for some of you, grandparents. And so I ended up, having
I
a
bet when he said that to you, you knew you could do it, right?
Yes, well, there was that too. There was that too, and it was the sense of strength that I got from his journey that I too could pick up and move to a different geography. In retrospect, it was not that big a deal. The country is really small. Airline travel is easy, and now we can kind of FaceTime with whoever we want to. But at the time, it felt like a very big move. I had a really successful 5.5 years at Caremore, which is a division of Anthem that provided care for older adults, as well as had offered health plan products to older adults, and then was recruited over to Scan, which is not a radiology company, even though it probably should be given its name. It's actually the Senior Care Action Network, and it was founded by a group of people we affectionately call the 12 Angry Seniors, community activists who wanted to change the face of aging in Long Beach, California. And then I became, the CEO of Scan, reporting directly to the board. And it's been just a tremendous journey. I've now been here for 6 years, actually, in just a couple of weeks. And we've grown the company from 2.7 billion in revenue to Next year, probably close to 10 billion, 500,000 health plan lives from 200,000 when I started with the organization. We've launched a number of different clinical entities. I think some informed, frankly, by our, kind of Jain faith. We launched a medical group for people experiencing homelessness called Healthcare in Action that last year saw 6,000 patients in primary care. We have a PACE program for those of you who know that type of model, and we've now launched 2 PACE sites. We have, 3 different primary care clinics that we've started, and an entity called Home-Based Medical. So it's been a really great journey. It's a really rewarding journey, and a very humbling journey. I think that was really enabled, frankly, by the sacrifices of our parents and the strength of our community. And so I'm just, thrilled to be here with all of you and excited to hear Chinar's story next.
Yeah, I think Dr. Sanghvi, actually, Chinar, you actually are not a Jersey person. I know you're from Georgia, so you're from the South.
I will say, I think what's really lovely and what I feel like I've heard is this like ubiquitous theme of like taking leaps. And, I very similarly, I think, to what you mentioned, Sachin, is, I also kind of made that big leap of faith to come from Georgia to California, and very scary at the time, especially because I was so close to my family, and I'd go home all the time during all of my training, and but it's been wonderful. So I think what I'll tell you is I started off, did a lot of my training, like I said, in Georgia, medical school, and then residency in anesthesia, and then came here to California for interventional pain training. And then was asked to stay on as faculty as soon as I finished fellowship. It was, I think, one of the best opportunities that I could have had. I think that has just really opened doors. I think a little bit kind of different trajectory and path, is a lot more of kind of the scholarly realm. I do a lot of clinic, but also more importantly, I teach medical students. I do a ton of research, and research really in things that I think are impactful. I think my dad, when I was growing up, used to tell me dream big and then dream even bigger than that, and then dream even bigger than that. And I think hopefully that's kind of what I've done throughout my life. So I think, whenever we talk about like, I guess, career in the kind of in the academic realm, it really kind of relates to, teaching, which is a very, very strong component. I do a lot of teaching for medical students, the residents, fellows. I direct a lot of rotations. And part of that teaching is really kind of engaging the physicians of tomorrow. In medical school, I feel like a lot of your achievements were much more personal achievements. And I think over time, what's been more important to me is the achievements of the people that I teach, because I think I may impact maybe a few hundred people here and there, but they're going to impact another 1,000. So that's been really crucial. I do a lot of research on things that are very important to me, things like health policy, telehealth access, actually, just innovative applications in terms of pain research. I sit on the admissions committee for the School of Medicine. And then, the last kind of bit is service. I do a lot of kind of work with the societies over here, and then a lot of work with kind of the School of Medicine. So yeah, happy to chat about any of that.
Yeah. So we have 3 really different backgrounds, right? We have teleradiology, right? And you're thinking about AI, and then we have the insurance realm, right? And then we have someone who's gone along a more traditional, but more like a mentorship, a teacher, like fellowship director, attending faculty kind of pathway. Jenner, I think you mentioned something interesting that happened to you recently in May. Do you want to talk more about it? It was like April or May, right? And tell us more about why you and your husband got married in Italy, because there's actually a really unique story about this, right? So why don't you go ahead and talk about it?
So I think there is a Rockefeller Foundation at the Bellagio Center in Lake Como, Italy. It's this incredibly prestigious organization, and where you kind of apply to be asked to basically do a convening over there or do fellowships over there. It's pretty incredible. It's almost kind of tight-lipped offering, but also what's really wonderful about it is that there are dignitaries that come over there. It's really this wonderful kind of where international leaders come together to catalyze breakthroughs, basically to reshape like systems and advance just kind of the global policy. And so and kind of some of the people that have gone there have been pretty incredible. I think one of the most recent people was like Ruth Bader Ginsburg has been there. So it was a really incredible opportunity. And we got selected to participate in this global convening over there, basically talking about food as medicine in kind of that broader framework of health and well-being, and kind of translating nutrition and prevention and whole health principles into kind of health professional education and also clinical practice. So there were, a lot of stakeholders from international organizations, FAO, PAHO, OECD, kind of global culinary medicine experts that were there basically to kind of talk about a consensus declaration about food as medicine. And so I was there for that convening, and then got married in Lake Como the week after, and it was fantastic.
Yeah, I remember you saying that you're getting married in Lake Como, and then later on we were just chatting, and it happened to be that she's also going there for a conference or for like a big forum, and she happened to get selected for something. I was like, this is so interesting. It's a unique story that makes you decide to, okay, like along with this, let me just go ahead and let's hold our marriage like right here. Let's just go to Italy at the same time when I'm going to this.
Can't complain about getting married in Lake Como.
Yeah, so Dr. Jain, you talked about, I think I remember like the time when I started following you, you were at Caremore, I believe. And I'm kind of curious, how was that journey of making that leap into the insurance world? And how everyone always talks about how healthcare insurance has a bad rep, right? What is it like kind of working from the inside?
Yeah, it's a great question, and I'll say I did a summer internship at WellPoint, which is now known as Elevance, was briefly known as Anthem. In 2006, I was in the middle of my first and second year of business school, and I interned with the chief medical officer of WellPoint, and I got to go to all kinds of executive meetings, and I was like, I will never work for this company, and I won't work in this industry, because I was shocked by how little clinical insight was being brought to bear to conversations that really required it. And, God has a very funny kind of sense of humor. 10 years later, I was leading a division of WellPoint, namely the Caremore division, which was actually the only division of the company that actually delivered care. So we operated clinics, we had doctors who staffed hospitals, and had a really bespoke clinical model that was focused on caring for older adults. And I think it's so important for doctors to actually, real doctors, not fake doctors, not doctors who want to run away from medicine, to actually go work inside of healthcare companies that are focused on the care of older adults, of all populations, frankly. And so I think there's a need for people to take their skill sets, take their clinical insights to new environments, and actually bring a physician voice into the room. And it's not always easy. And I think we also need more physician CEOs. I happen to be one of a few in the insurance industry, but the job is to not fall into the usual trap, which is to create distance between the financial decisions, the coverage decisions we make as insurance companies, and the people who actually receive care on the other side. And I think that was a real fundamental work. My father, I think, was very proud of what I was doing, but also worried that I might lose my soul in the process. And I will say, I've kind of tried to maintain a foothold in clinical medicine throughout it all. Many people think I'm actually crazy for this. I'm right now doing 2 shifts a month at the UCLA VA in an urgent care. And, I think what it does is it makes sure that you aren't creating too much distance between the policy decisions, the business decisions, and the clinical decisions. And the reality is that American healthcare has suffered a horrible moral and ethical numbing over the last 20 years, wherein we've stopped seeing patients as patients, we've stopped seeing doctors as doctors, and we're starting to treat it like it's any other business. And I think that that was really corrosive language that started to enter what is truly a sacred, field, and what is truly, I think, very different from other businesses. And I think part of the work of this group of people, and frankly, all healthcare professionals, is to actually like re-inject soul into the work that we do. Because absent that, you know, the system that we have will be the system that takes care of us when we need it, and that's actually quite scary.
Yeah, you bring up such an important point, right? Um, yeah, no
I got to
one,
tell you,
yeah, go
I
ahead.
fully agree. Even in my career, I viewed myself, I spent 17 years in the private equity owned radiology space. I viewed a lot of what I did as protecting the docs from private equity. And, I agree that my dad would have been proud, that I'm like doing this stuff. At the same time, there were points, like I told you, that when I was with a 700-person rad group, there was no time, to read clinically. And, the administrators, they don't want you to read. They want you to handle the stuff that you need to handle. And I'll tell you, the best advice I ever got was to stay clinical. If you don't, your colleagues that you're trying to protect, they won't see you as a fellow physician. They'll see you as maybe worse than some of the business suits that are there. And secondly, things change in medicine. You've got to keep abreast of it. And by staying in practice, it's definitely a good thing. And then thirdly, there's nothing like the camaraderie and keeping your passion for clinical medicine. That's why a lot of us went into it. So I completely agree with Sachin. I'm really glad that he's had the career he has, because not a lot of people are in the insurance industry, but I guarantee you he brought a clinical aspects to a lot of the things he did. I I have no animosity or ill will towards private equity either. Like, there's good private equity, there's bad private equity. We'll see what happens with private equity. There are some of my med school colleagues, their practices are owned by private equity, but they retain a strong voice in it. So it's yet to be seen. I definitely don't think the overall track record has been good, but maybe that will lead to another change that we see. Because certainly my kids' generation is not going to be approaching medicine the same way that we did. I know Chinar's younger than me and Sachin, I think. But it's definitely an evolving field. So everyone needs to take these lessons. You know, I'm always giving lessons to the younger generation about this stuff.
I will chime in and say, as somebody who's really kind of 80%, 75% clinical, what's really lovely with just that kind of FaceTime with patients, and also in kind of what I do is the FaceTime with patients, but also like when I have students come, and it's just their curiosity, that kind of like spark. Because I think what happens as we get longer and longer into doing this is you start to lose that spark in terms of like, oh, this is a good day. Like, I am excited to do what I've been doing. And I feel pretty lucky, at least in kind of the pain medicine realm, that the field is growing at a breakneck speed. So there's new things around the corner all the time. But there are certain things where you start to get kind of over time, like, oh, well, like sometimes it's like, oh, well, here's another epidural steroid injection. But it's that curiosity that especially I see with kind of some of the students that come through and kind of some of those teaching opportunities that I have. And even with clinic, it's, I always tell patients it's like first time, maybe 100th time for me, but first time for them. And so I think kind of that holding on to that is really, really important.
Yeah, I think
Yeah.
there's a term for what Chinar is describing, which is really ethical erosion, which is this notion that, we stop seeing the thing that we're doing as the thing that we're actually doing, right? And you start to disconnect yourself from the work and its impact on others. And I think that's the work, is to actually kind of stay ethically grounded and kind of live a life of ethical renewal. And it's hard because it's very easy to kind of get into that routine and stop seeing things for what they actually are. But I think, connecting it to our faith, I think that's the work, is to always see it through the lens of the other and actually, keep grounded in the principles and the ethical foundations of what you're actually doing.
Yeah. So important, right? Um, so Dr. Shah, I'm kind of curious, since we talked a little bit, we went deep into a bit of insurance talk. Now I'm thinking about all the hype AI gets, and then you using it and being in that world on a regular basis. What do
Yeah.
you have to say to everyone in this call who may or may not be aware of the realities of AI in healthcare, like the good parts, the maybe like things that are questionable that you really need to watch out for? Like, what is it really like?
I mean, it's a tool,
Yeah.
right now it's not reading films on its own. It's not
Yeah.
making decisions on its own. It's there's so much tedious work that we do in radiology, measuring lesions, crafting dictation reports. We used to have transcriptionists for that. We used to have people hang up our films. We got to do we a lot of this work is like done by us, whether it's digitally or not digitally, but we're like editors of our own reports. AI as a tool is helping in those arenas. It cannot make decisions, it cannot make clinical decisions yet. And it's still in its infancy. It's almost been about 9 years since I first used the first tool that was even called AI in radiology. And that's a long time. I was definitely on the very, very, very early adopter end. Even some of the tools I used 9 years ago, some of the radiologists are just getting to them now, for dictation help and things like that. And it's it's an efficiency method. It doesn't make me faster or do anything, let me put it this way. Some people are like, can you make more money using AI? And really, we are so bogged down with tedious things, and radiology is kind of a meticulous field that all it does for me is help me take better care of my patients. That's what I want it to do. I think the other thing people say is like, is anyone going to go into radiology anymore? Um, I I've gone all over the spectrum in that, and you're right that I have a bird's eye view, to basically India's creme de la creme software engineers. These folks are like from the top 10% of their class from IIT, from the top campuses of IIT. So they are iterating the same kinds of things that OpenAI and Anthropic are doing here in the US. And sometimes they're recruited to those companies. And I will tell you that some of the stuff they're doing is just mind-boggling and crazy. But at the same time, every field in medicine is eventually going to get affected by AI. And by the time radiology decisions are being made by software, maybe your primary care doc is going to be a robot or something like that. So I've actually started to tell medical students. I just had one the other day, and this was a person who was switching residency. So they've done surgery, they had experience, and said, I really love radiology. Am I making a terrible decision? This person's father actually came to me as well. Somebody pretty prominent in medicine, probably somebody Sachin knows, and said, can you advise him? Because I don't know if radiology is going to be around. And I actually said, you should go to radiology because this is clearly where your passion lies. You have been around the block, you've tried another residency, you know what you want. And I'm telling you, by the time anything happens terrible in radiology, things are going to happen in other fields of medicine as well.
Oh, wow.
Yeah,
Yeah.
and I mean, maybe I'll just make a small plug again for a kind of an ethical argument around AI. I think there's a real need for people who know how to use technology for good. I mean, these are all just tools. And I think, a lot of times the conversations that happen inside of boardrooms are, how do we use AI to do a big cost takeout? I think the question is how do you use AI to serve people better, to actually do the things we never thought we had the resources to actually do when the cost of compute has gone down as much as it has? How do we actually use AI to augment systems, make jobs better, make the work better? That's I think the role of healthcare leadership over the next 3 to 5 years is to actually show up as a champion for AI, as a vehicle for better patient care, rather than a vehicle for administrative cost savings alone. I mean, that's necessary, but also, I think a challenge.
Think as
You know,
someone who
go ahead.
uses AI in clinical practice every single day, day in and day out, what I'll tell you, and the biggest impact it has is your face time and eye contact with a patient. And the patients can tell and they feel it. I mean, it is so obvious. And I think a good example is usually in pain medicine, we deal with a very, very complex patient population. It's not it's a challenging patient population that has a lot going on, and oftentimes a lot of your like what we call press gainy scores that come back and the ratings are not very high. We've been fortunate enough here that our clinic, we've had incredibly high, like 90th percentile plus press gainy scores, and not to say that it's all attributed to AI. But I will say that, Sacramento Magazine does these like top doctors, and we've had a lot of our physicians, me included, be in that Sacramento Magazine top doctors in the past 2 years. And a lot of pain physicians don't make it to that list. And I think part of that is that ability to really interact with and have that FaceTime with the patients, and AI makes that possible. I think it can have, I saw one of the comments saying about kind of some of the AI hallucinations, and
Yeah.
that happens more times than I can tell you. And that's why it's not AI without oversight. And so I think that's really, really crucial, is the oversight component. But I think, just from a patient standpoint, it has made a big difference.
I think what you're describing is kind of human in the loop AI, right? Where you do need a human physician or someone who's any sort of subject matter expert in like whatever aspect you're using the AI for, right? To be reviewing these outputs on a regular basis and to be reviewing the data that's feeding into them, right? Because AI models are only as good as the data fed into them, and they're only as good as the people who are reviewing and constantly monitoring, regularly keeping track of what is being outputted, right? So like the hallucinations are always going to be there. I was going to bring that question up just because we were already talking about everything. And then I see like someone also asking about healthcare admin being one of the biggest opportunities in AI. I think that you covered that, right? I think that it can augment healthcare. It can augment a physician's ability to take care of a patient. It can't fully take over, right? And I think like I don't know if you want to talk more about that, but yeah, I think that it's always been a super interesting topic for sure.
I think one of Sachin's points was that like and I know Chinar supported it, was taking better care of the patient using AI. And I think our values, this community, quite frankly, the Indian community in general, I have actually been pleasantly surprised. I see pharma execs, I see healthcare insurance execs, of Indian diaspora. Their priorities are pretty straight. Like they want to use AI to help patient care, stage cancer earlier, find cancers earlier. If it's a win for the patient, it's usually a win for the bottom line eventually too.
I agree, Samir. The one thing I will say, and this is maybe it's specific to the Jain community, not specific to the Jain community. We do have I think, an epidemic of South Asian fraudsters in healthcare. And I think it's like a conversation we actually have to we actually have to have as a Indian community, which is, I think there is a loss of ethics, kind of a disconnection between like the actions people are taking and their effect on others. And I think one of the challenges we face as an industry, as a community rather, is that people are increasingly seeing us through that light, as like people who are operating unethically and kind of get rich quick schemes. You've got, physicians who have been kind of caught out for Medicare fraud, overutilization of unnecessary procedures. That's a very common thing that you see. You see folks who've been caught falsifying revenue, creating phantom customers. And again, I think the culture of success in the South Asian community can also be our downfall, because you see people taking shortcuts all the time. And frankly, it gives us all a bad name, because
Yeah.
that reflects back onto us, because we're such a visible minority,
Yeah.
very positively in many ways, but also negatively in other ways. That I think one thing this community can do, because there are such strong, ethical underpinnings to our faith, is to try to be a voice for good and actually speak up a little bit more. I think one of the biggest tensions we face as a South Asian community is like a lot of the hidden curriculum of our community is like, just keep your head down and do a good job. And sometimes you have to kind of lift your head up and say, actually, this isn't right, and kind of go back to that kind of ethical core, because there's a lot of bad behavior in healthcare. There's big health systems that are bankrupting patients. There's a lot of surprise billing. There's a lot of, racial and ethnic discrimination that happens, a lot of racist behavior towards people like us, in a lot of different ways. So I do think some of what I'm hoping for from this conversation is we do talk a little bit about the ethical awakening that I think needs to happen, in our community. And again, I think we have many shining stars, people who are doing things right. But a small minority of kind of folks can run the risk of really ruining the reputation of our community.
It's really easy to, like in my field in radiology, 30 years ago when I trained, a great radiologist was somebody that made great diagnoses, a master diagnostician. And I have seen over the years, and Sachin, you can probably finish my sentence. In my field, a great radiologist now is considered somebody who produces the most work, who does the most RVUs. How many films do they read? He's great, she's great, because they got through the work fastest. And that is corrosive. And, if you take our minority that tends to be at the top of our game, and we want to be, achieving and being the best, you can pervert that and say, oh, I better be the fastest. And let me tell you, if you're trying to be the fastest and make the most money in healthcare, that can easily take you down a road of fraud and abuse and waste and all the things that we were trained not to do.
I think I'll say, some of these points are, when you talk about such in terms of like, we've been taught to just kind of keep our heads down and, do your work and then be done with it. And, part of that I think comes from our parents' generation, which was they really didn't have the opportunity or even the capacity to be able to voice their opinions or say that,
They
hey,
didn't have the margin. Yeah, they didn't have the margin. Yeah.
they didn't have exactly. And there wasn't kind of, and I remember, when there were a lot of new policy that changes that came out about Medicare covering X, Y, and Z procedures and things like that, that honestly were detrimental and harmful to patients. There was kind of this point where even I was like, well, I mean, it's fine. You just go along with the punches, do as they may. But, I think part of the problem is that advocacy is, I think, something that very few of us do. And so these voices that we're talking about, they don't get heard very often. And part of that is physician voices, and they get drowned out in kind of a lot of the other noise that's happening. And physician voices that really talk about kind of a lot of what our Jain principles are talking about: nonviolence and thought, not, the community and giving back to the community. And so and I think part of that comes from actually getting out there, whether it's with social media or, in what I do a whole lot of is I do a lot of kind of news media and publications about these things, because that's kind of in the academic realm, how we can get our voices out there to talk about kind of disparities in healthcare, gender disparities that we see in leadership, talking about, access in terms of racial disparities that we see. So, I can't agree more with what both of you guys have said.
You know what's interesting? So, okay, I may insert a change of my background now. So, I grew up here, but I went to India for med school. Okay. And then I came back here. So when I was in India, my medical school was a kind of like a private rural community medical college in an area where we had like 36 villages under our extension program. We were a tertiary referral center. So we had patients even coming from out of state, especially just for some high level care. And a lot of our patient population could not afford even just like these regular, most of the run of the mill in radiology imaging and like highly expensive lab tests, et cetera. So the way that I learned growing like through med school was you really have to think about what a patient can afford. These patients are earning maybe max 3,000 rupees in a month, like, 1,000 rupees in a month, who knows, right? And when you think about even like the most simplest labs, they're going to be like 100 rupees, 50 rupees. A CT or MRI is like 3 or 4,000 rupees. That's like already a whole month's paycheck. So we used to really have to think, is it necessary? Do you really need to order this? Can you get this information by asking a good history? Can you get this information by doing a proper physical exam? And I think some of that, would you say like some of that is getting lost nowadays
Oh,
because there's
totally
so
lost.
much tech
Totally
that's
lost. My
available?
my my mom comes back from every doctor's visit and says nobody examined me. I mean, that is completely lost. And we will order, a radiology study oftentimes where we would have done a physical exam before. That said, I think, we have a payment system here that most people are covered by that actually gives people access to those
Yes.
tools and technologies. And so the practice patterns are certainly very, very different. But I think the art of listening is completely lost. And I think the bigger topic that often gets underexplored is the horrible labor arbitrage that's taking place right now, wherein we're creating false equivalence between MDs, PAs, nurse practitioners, RNs, community health workers, and lay people.
All
And we've kind
providers.
of we call them providers, and we've eroded, we've essentially eroded the notion that there is clinical expertise. What Samir said about what we value from a radiology perspective has turned into, I think the transactionalization of every aspect of American healthcare now is such that there is no such thing as a relationship between a doctor and a patient.
Yeah. And so I saw a question in the chat, which is kind of out of curiosity, how do medical professionals perceive Canada from a medicine standpoint? Healthcare is free here, but at the cost of higher taxes. We do see longer wait times, but with no financial burden. And I think this is more of a topic of kind of a centrally managed, like, like having a central payer, a single central payer, which is the government, as compared to multiple private payers and a mix of private, public, everyone with different, different guidelines on what they're going to reimburse and cover, and they're like, what would you say? Like sometimes they're like picking and choosing, right? Like, whereas like, in some other countries, everything is kind of centrally done. India also has a unique one too, because I remember when I was there, I could just go to an ENT doc to get my tonsils looked at if I had like a grade 4 tonsillitis or something. And that's the way it was there. That if you had something in your throat, you just go to the ENT clinic. You're not going to your PCP and then getting a referral. You're just going there. Same thing if you had a
Yeah,
migraine.
but Shika, to push back,
Yeah.
you're also having people who have, normal inflammation of their pharynx that are going to see ENT doctors in
Yep.
India too,
Yep.
and are getting a bunch of tonsillectomies that they don't need. I mean, that also happens because
Yeah.
that, India is also the most consumer-directed, um, purely consumer-directed healthcare environment in the country, in the world rather, wherein there is no, as much as people hate utilization management, there's no real arbiter of appropriateness of care there. And so people get a lot of things for the wrong reasons um, all the time in India.
I think the other thing that is really, really important is the access to care, and
Yeah.
especially, I think it's deplorable to me that there are places where you can't get access to care for months on end. I think, especially in, countries, Canada, for example, access to specialty care, especially, I mean, that years sometimes.
Yeah.
I have one of my fellows who is out there, and she said, "Oh yeah, a patient would be lucky if they got in to see me in a year." And but in a year later, they are already paralyzed by that point, So it's I think there are fantastic things in terms of, the ability to get access to a primary care provider, things like that. But then it comes with its pluses and minuses.
Yeah, it's different. I think it's better than the NHS right now. I think the NHS might be third, if you're looking at the US, Canada, and the NHS. Um, in terms of what has happened to the NHS is that it's basically decayed, into a third world type system. Whereas I think at least Canada, they're trying to use AI. They're trying to use modern healthcare tools like EMR and everything else. They are doing their best. We have so many deficiencies in the US system that it's tough to cast stones against any country's healthcare system, quite honestly,
Look,
because ours is so broken. Yeah.
I think when you do cross-national comparisons, what you quickly see is that there's just very different cultures of consumption
Yeah.
and very different attitude towards, end of life across the globe. And so, the United States, everyone with end-stage renal disease is offered coverage for dialysis through the Medicare program. And in many parts of the world, if you have end-stage renal disease, you die.
Yeah.
And that's just, the difference in culture. In America, we believe everyone should live forever, regardless of their underlying condition. So we will give you, therapies for cancers that extend your life for 3 or 4 months at a huge cost to your employer or to society writ large. And that's completely normal and that's expected. That doesn't happen in Canada and, England quite as readily as it does here. So I think the big national conversation in the United States is really a conversation around, what is our culture of healthcare consumption? Like, is it sustainable? And what changes do we need to make? And, whether you're Republican or Democrat, there are some very good things about the MAHA movement, specifically focused on, like having the hard conversation that people don't want to necessarily have around lifestyle and the extent to which we have kind of an unsustainable burden of chronic disease in our country that is frankly mostly preventable. A lot of the conditions that many people see as inevitable are actually preventable. And so again, these are the cultural nuances that exist across geographies that are important to compare and talk about.
Yeah, absolutely. I'm gonna make a little pivot because I saw an interesting conversation thread in the chat. I may ask Dr. Shah about this. Since you've been in private equity and you're at a startup at the moment. Um, so we have a question about for folks here who want to build a health tech startup, where and how should they seek early stage capital? The top three places and advice you have for someone starting up. And then I have a follow up in the thread for this where they were like, let's say if a founder doesn't have the 600K to raise from friends or family, they will not be able to build at all. Furthermore, crowdfunding rarely works for STEM-based ventures. So they're asking about specific examples of platforms you would advise someone to use for crowdfunding as well.
Yeah, I mean, that's a good question. The sheer problem is the number of healthcare startups there that are going on right now. Your competition is immense. Students are choosing as their senior projects, healthcare, right? It's pretty easy. The barrier is pretty low. You have access to an LLM, you have access to, coding talent, probably your college friends, and they can make an app that would address some issue. Really, scaling that, making that into a really valuable idea is tough. It seems like the folks that get capital right now are it's almost like a joke. If you have a Stanford, Carnegie Mellon computer science degree in your team, quote unquote, you're getting funded. Yet if you're at Ohio State and have that behind your CV, it might be really, really hard unless you really have some great access to capital. I've seen it. I know it's stereotypical, but I've seen kids of wealthy, titans seem to have their startups funded before anyone else. I think I don't have a cut and paste answer for you for that. It's really hard. My startup started by some scrappy students. They had an idea to address TB. TB is the number one killer in India. It's 3 times as bad as HIV as far as infectious disease. So that they started there. So, within 2-3 years, there were 15 startups in the area and in TB, and they had to be the best. And it's not just India you're fighting against. You're fighting against China and Korea and every place else. It's a dog eat dog world. I have no great answer. I don't know if Sachin, if you have an answer, if Chinar, you have an answer. Maybe you see some.
I'll be a kind of a countercultural voice if you'll allow me. I think most startups are snake oil in American healthcare, and most people start startups before they know anything. And
Yeah.
so, and the reality is we don't talk about this enough, and people waste literally years of their lives doing absolutely nothing, without asking even the most basic questions to start with. A lot of the kind of literature on entrepreneurship says that the best healthcare entrepreneurs are actually over 40. And the popular image of the startup founder is the 25-year-old, from Stanford or MIT or Harvard or whatever it is. But the reason that I think that, 40 is probably better than 25 is you actually know some things. It's also happens to be where your risk tolerance is the lowest. And so I think it's a really complicated dynamic that I think folks need to navigate. But I think you also have to really introspect why you want to do a startup. Are you really doing a startup to solve a problem that needs solving? Or are you doing a startup because you want to get rich quick scheme? In which case, you should just buy a bunch of 7-Elevens like people did in in the 80s.
Totally
If,
agree.
if you really want to get rich quick scheme, because it's the economics are frankly far more predictable and more reliable. And so I think that the issue though is that there's just a lot of snake oil and a lot of people who pretend that they want to help people who couldn't care less about actually helping people. And that's the thing that we all have to kind of really push is for more authenticity around mission, purpose, why we're doing what we're actually doing.
Yep.
As someone who's
Risk
had to
tolerance.
go ahead.
When I see a young person who's at a startup and they start their job at 9:30, 10, after they go to the coffee shop and get their, large venti coffee, like that's not startup life to me. Like startup life is you're barely existing. You are, obsessed with work from the moment you go to sleep, and because you're trying to solve something, right? Uh, and Sachin is totally right. Like I've had five bankruptcies. I've gone through five bankruptcies. My risk tolerance in this arena is extremely different from most of my colleagues who don't want to do this or wonder how did I end up on this path. Uh, right? Like so by the time I will tell you that when I joined Cure, and I think I started this conversation by saying I'd been through some rough periods. I knew I could make Cure successful. I knew what it took because I've had a lot of experience and my network is very large, and I have a deep understanding of what works in AI, and it's not the algorithms, it's the workflow. That's all that matters. Like I spent 2 years, uh, and Cure wanted to commercialize fast, and the board, we're owned by a board, and probably a lot of people know the private equity companies that own Cure. By the way, Merck is part of our ownership structure, Sachin, and they want money fast. And I was like, nope, gotta wait a couple more years until we fix the workflow and make it.
The,
Um,
the other thing people don't realize is kind of investors stack the deck fully for themselves. And so,
oh yeah,
there's
fully.
something called a preference stack, wherein, all the common shareholders, which include the earliest investors plus the employees, are always, subordinated capital relative to the last money in to a startup. And so unless you have a grand slam outcome, the people who are going to always do the best are the ones who had the last money in. And then the employees, the founders, oftentimes walk away with nothing. And and this is just a very pragmatic point that somebody made to me many years ago, which I really thank them for, is when you actually look at the compensation packages, like the net present value of like, you know, your base comp, your incentive payments, and your stock, if you're working at like a non-startup company, relative to what you get at a startup where you're taking basically a lower salary and a lottery ticket for your compensation, you're almost always, that you're almost always going to do worse, even when there's a good outcome for the startup. So it's just one of those things where I think people oftentimes learn these lessons after they've gotten burned because they're not involved in a community where they can actually ask these questions. And that would be my one advice to everyone here is actually be very comfortable reaching out to others for advice, for help, for
Yes.
perspective. That's what we're all here for. And we all ask people before us. And I think the goal is for you to not make the same mistakes the rest of us made along the way.
Mhm.
And so, again, people are mostly going to tell you to do what they did. So I would avoid the like very highly directive career advice that dominates the South Asian community in general, like, oh, do what I did. No, you've got to carve your own path, but certainly tactically, like you should really learn from the wisdom of the community
Oh yeah.
that'll happily share it with you.
I
Yeah,
think
I'll share it with my contracts, what I've gone through, because 90% of it is hidden. And as Sachin said, about your mentor, you need some good mentors who can tell you, oh, you need a riding escalator in your contract because every year you should get paid more. These things are things that are not talked about in medicine. Typically, especially folks of my generation, we were trained to just follow the rules, do as you're told, or else you're a bad soldier. So, you need to understand the tricks and trade because absolutely Sachin is right. Yet I've been fleeced so many times. And I'm not doing it for the money. I'm absolutely not doing it for the
And I
money.
would say the same thing around angel investment. Like put your, take it from somebody who's been burned many, 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 many times with angel investments. Put your money in the S&P 500. If you want to buy a lottery ticket, put your money in a startup. Like chances are you're just going to be you won't even be able to take the tax write-off because the company will get sold to something else for parts and it'll just be sitting there in equity that doesn't ever get marked down. So just,
You're not going to win.
you're not going to win.
But I think the kind of factor also here is like there are mentors around you and make good use of them. I always say like I have built my entire career, I think like standing kind of on the shoulders of like stalwarts. And I think that's really, and people, like, I think a lot of these opportunities that I've gotten, they're unfathomable. I think to me, if somebody told me as a medical student that you were going to do X, Y, and Z things, no way. And I think part of that is kind of these mentors opening doors for me. But I think that has to be a reciprocal exchange. So while they open a door for you, you have to be like, hey, these are all the things that I can do to kind of keep that door propped open. So it can't be, mentorship is a two-way street. And so if you can kind of collaborate together, I think that will just make your experience more enriching.
I think a huge thing and a recurring theme I'm seeing all of you bring up is that the people who are most successful are the ones who, first of all, have had some sort of lived experience or have gone deep to actually learn the workflow of whoever their target demographic is, who have actually lived in the thing and actually noticed a problem they actually like insatiably want to solve. And that's why, Dr. Shah, you're talking about how, they're spending all their living hours on it because this is something that they have noticed as an actual issue that they have actually experienced or they know other people have experienced. I think the other thing is that people who are successful also acknowledge that they don't know what they don't know and they don't know what they haven't been exposed to. So instead of just making assumptions that, hey, I'm going to do something fancy and cool, but it's actually not relevant at all to someone clinical because they didn't bother to ask. They didn't bother to do their due diligence and do that market research, right? I feel like I've helped along in a lot of like due diligence discussions for like a lot of like health tech startups and stuff, right? That pitch to these communities. And I think this is like a recurring theme that comes up, right? It's like, do they have a clinician on their team?
There you go. That's the first question.
That's one of the first things.
Yeah.
Did they do their research? Do they consult like the right subject matter experts? Yes, they have a clinician on the team, but does that person even practice the specialty that you're trying to gear or like, target?
Half the time, no.
Is someone just like a trophy doctor there on the board? Or like, are you actually trying to make an impact? Do you understand your population? Are you keeping your solution simple? I think those are some really interesting themes, right? For sure.
Yeah, well said.
So I see another question about non-clinical paths. So someone says that they're a young physician from India looking to build a career on the management and strategy side of healthcare. For someone looking to pivot into a non-clinical path, what would you advise as the best foundational place to start? And what's the biggest mindset shift required to succeed in healthcare operations versus clinical practice?
I'm going to let everybody take a shot at this, but I just have to reiterate what Sachin said. Like when Sachin went to business school, not everybody was going to business school. I actually almost went to business school in my residency and was dissuaded from it. Then in my fellowship, I almost went to business school, again dissuaded from it. By the time I had time to do something in business, I had like morphed it into a management master's where I was practicing because I knew I wanted to do this. And so, the first time I wanted to do it was 1999, Sachin. And nowadays, I would never tell anybody to do that. I would, because they're a dime a dozen. It doesn't offer any differentiation factor. Maybe it's just a great way to get, tuition dollars into the system. I think you have to be a risk taker and do something different. You want to get into the management and strategy side. Prove it. The early ways in my career, I've seen radiologists gain leadership. How did I gain leadership in my first private practice? I was sitting by the president. We were doing peer reviews at 10 o'clock at night because they were due the next day. You literally had to sit by a mentor who could give you the apprenticeship that you needed. And that's how leaders were chosen. You did the hard work for 10 years and somebody said, okay, you're the next in line for X, Y, and Z. So there's no shortcut. There's no easy way to, becoming a healthcare strategy management guru. You have to find somebody who's doing hard work and take over for them and follow their path. That's what I think. but I'll let you both address that as well.
Yeah, I don't know if I can comment on kind of the strategy standpoint, but I will say that whether it's clinical or non-clinical, eh, I think you can do things to expand and really step outside of your comfort zone. A lot of the work that I do now is associated with culinary medicine and doing international policy related things and, doing things in terms of education. And none of these are really related to kind of the clinical practice that I have. But having said that, does that lay a foundation in terms of everything that I think about and how I educate, whether it's, somebody who's completely outside of this field, for sure. And I think it makes what you have to say that much more important.
I think there's a bigger question that everyone needs to ask if they're going to pivot to the administrative side of medicine is, do you want to be impactful or do you want to be successful? Because a lot of it is just about success. And I think the question just becomes like, oh, I just want to have a good job where I'm in charge of some stuff. We don't need people like that. We actually have enough of those people. We have so many of these people that we trip over them everywhere we go. We do need people who actually want to solve problems. We do need people who see problems in the world and actually want them to get better. And so when somebody says vaguely, I want to do strategy or I want to be in the management of things, like to do what? To do what? Towards what end? You want to be in charge? Okay, like join the club. If you actually want to solve a problem, you then actually have a shot at having an impactful career versus just being successful. And I think we don't talk enough about this. I think particularly in Desi culture, being successful is like good enough. For like, oh, okay, like I worked at X, Y, and Z firm. I'm successful. We equate that with success, and it's just not the same thing. I think you actually want to leave the world a better place. And so it's forcing yourself to ask sharper questions of yourself and of others, which is like, what am I actually going to be doing to improve other people's lives? What are the degrees of freedom I have in this role to do that? Because, and again, I think the sharper you can get that question, the faster your career will grow. Because that's so rare. That level of conviction and focus is so rare that you're not going to get lost in the huddled masses of people who just want to be in charge and make a couple of 100K for not a lot of work, which is what a lot of people who want to do work in the administration of healthcare actually want to be. So I would push the conversation to be, to reiterate, do I want to be impactful or do I want to be successful? Because they're not the same things.
Yeah, absolutely. I think you're talking about success. Someone asked specifically for you, how did you build such a crazy following on LinkedIn? They're in
I
venture
didn't.
capital and distribution and network is part of their business, so they're curious.
Yeah, I mean, I'll just be honest. I don't post like normal corporate BS and corporate pablum. I mean, and I try to speak from the heart. I try to speak uncomfortable truths. And I think there's frankly not a lot of people who do that. If you fire up your LinkedIn right now and you looked at, it's a celebration parade of personal achievements. It's a lot of humble bragging. There's not a lot of kind of connection to your personal identity. I think we're taught to anonymize ourselves and not tell people that they're from Jersey, not tell people that you're Jain, not tell people you're Rajasthani or Gujarati. People anonymize themselves into, neutral bots. And I've just tried to be myself. And, I'll say there's a cost to that. There's a hidden cost to that. I think not everybody wants you to be yourself. But the reality is you just have to kind of be yourself. And I think people look for authenticity and they look for voices that are actually talking about the real things. Again, that's kind of, I think, a little bit of how I've built a following. And again, I will say, like, some people think it's great that I have this following. Some people think it's not great. And again, you just have to be true to yourself in that way.
Yeah, for sure. I follow you and I know that I've definitely shared a lot of your posts with some of my friends. So, just because, hey, this relates, and There's an interesting question about pain medicine, actually, specifically. So interventional pain medicine is an important part of seniors' life. What are the changes in this department to help seniors? Does mobility equipment developed in partnership with MDs in this space? I don't know.
Yeah, that's a tough question that I think I could delve into a 2-hour lecture about.
Okay.
Won't do that. But I mean, I kind of mentioned this, that the field of pain medicine is growing at a breakneck speed. And part of that is actually coming from companies that are developing and, wonderful scientists that are developing therapies that are out there that I couldn't even have, honestly, some of the things that I trained on as a fellow, I couldn't even, and what I'm doing right now, there's just so much breadth. We are doing minimally invasive spine decompression. We have radiofrequency ablation that we can help with to help with back pain. I mean, it is almost like every couple of months there's a new therapy that we can offer patients that really, and part of that is that, over time, I think a lot of patients, they're kind of shying away from surgery. And that kind of is really where we come in terms of all of the options that we offer. So, kind of back in the day, it was like, here, you got your little steroid shot and you're done for the day. And, but I think now there are therapies that are incredible. We have options like a spinal cord stimulator, which is basically like a pacemaker, but for your spine to help with pain. And I've seen patients who were unable to walk because they were in so much pain. And I've put in a spinal cord stimulator and now they're having fantastic pain control and able to walk and take care of their grandkids. I think I feel like it's the world is your oyster in terms of the therapies that are offered for patients right now. And I always like tell patients when I come in that, I'm going to lay out kind of your path in terms of like, there are backups of backups of backups of backups of options. So tough question.
Yeah, absolutely. I have one last question, and then we're going to pivot to some special announcements, and like a wrap up and then special announcements. There's a question about AI and education. So there's a high school student wanted to ask what seems to be the biggest change in healthcare education in this decade as compared to a few decades previously. And is AI at this point producing any significant changes in the way curriculum is being taught?
A good one.
Yeah, I'll kind of start off with that one. And great question. I will tell you that when I did medical school to now when I teach a lot of medical school courses, a lot of kind of what we did was we just go in and you'd sit there and you'd take your little notes and then you'd go back and try to read through those notes. And I think now kind of curriculum has changed drastically from that. A lot of kind of the classes are online. There's not as much kind of in-person interaction. But what that has afforded is the opportunity for the students to actually be able to take time to do a lot of things that are outside of what is normally part of a curriculum per se. So what does that mean? It means that they have the opportunity to do things like talk about wellness and well-being and how that's important for patient care, to talk about prevention, to talk about kind of some of the culinary medicine things. So I think that's where, and I think what the wonderful thing is in terms of kind of medical education as it stands right now is that the students, where previously there really wasn't that much voice in terms of what the students wanted. It was like, this is the curriculum, these are the competencies, and here's how we're going to teach it. But I think now there is this almost personalization in terms of the curriculum, which offers a lot more clinical capacities and clinical capabilities and really kind of tailor the education more towards what a student is going to do in the future.
I can tell you from radiology, COVID was probably the biggest thing that changed radiology education. When the attendings started reading from home, you lost a chance to be next to that attending and basically, getting one-on-one teaching from a radiologist. And that has significantly impacted how residents are taught. A lot of residents are are trying to learn radiology from textbooks and internet pages and things like that. It's just not the same as a human being pointing out certain patterns of pathology that occurs in radiology to you. So rather than say AI, I would say, that shift from, teleradiology was still viewed as a very weird thing in 2020 until the pandemic. And now, much of radiology has shifted to a remote location. Most people are like, AI is going to take away radiologist jobs. I say, no, we kind of did it to ourselves when we had two things. We had the internet and we had digital imaging and PACS. First of all, clinicians look at their own films now and learn from their own films. We used to control the films. And then secondly, we're not there in the hospital where these clinical decisions are being made. We're not in the trenches with the docs. You know, that's gonna alienate us as well. So I'm not that worried about AI taking away radiologist jobs. I'm worried about us not being the doctor's doctor is what a radiologist is supposed to be. And if we abdicate that role, then we'll find ourselves without jobs.
I think about this a lot, just in the context of in a world where knowledge is as democratized as it is. What is the role of a doctor, right? Anyone with an iPhone today can fire up ChatGPT and ask a question and get the clinical knowledge. So what are medical schools really going to teach students if the fund of knowledge is as widely distributed as it actually is? And it used to sit on books like the ones sitting behind my shelf that you literally had to go to the medical library to pull out the book and like find the fact. And your persistence in finding those facts was what differentiated you as a physician. Today, I think the thing that's going to matter the most is your judgment. And I think medical schools are going to kind of move towards more strongly teaching clinical reasoning, judgment, and ethics as the foundation of the curriculum, which were always kind of peripheral subjects, part of the hidden curriculum. It's going to be more part of the explicit curriculum. And so I do see an increasing focus on like professionalism and professional development, substituting for where right now students are spending unbelievable amounts of time on fund of knowledge alone.
I think I will say, just to I think those are factors and parts of the curriculum, but part of what comes with the AI is actually the fund of knowledge and kind of some of the misinformation. And so I think this is where that education is so much more important because, at the end of the day, I tell people, I can teach a monkey how to do some of these procedures, but really what is really the most crucial part is the EQ skills and really like do you have the compassion and do you have kind of the capacity to be able to really have a clear differential thinking, because you can teach these procedures and you can teach X, Y, and Z, but that fund of knowledge is at the end of the day, what's going to get you and what's going to make you a good physician. So it's that fund of knowledge and kind of the EQ skills that really kind of make you a strong, and compassionate provider.
Absolutely. Well, thank you so much to all of you for a great session. I know we have a few minutes left till it is 7 p.m. Pacific, 10 p.m. Eastern. We have a special announcement from our Director of Finance, Ronak Jain. And he's going to announce something cool. So yeah, take it away, Ronak.
Thanks, Shikha. Jai Jinendra, everyone. Before I even go to the announcement, I just want to thank the panelists for showing up today, for Shikha for hosting such a informative session. I'm not in medicine, but I had a lot of takeaways from the session around entrepreneurship, around having impactful versus successful careers. So a lot of good insights for me as well to take away, even after not being in medicine. And now on to the special announcement. So we'll do some drum rolls. But I'll share my screen while the drum rolls are coming through. 1 second. And let me know when you can see it.
Yes.
Yay.
Awesome. So we're super excited to announce our YJP Convention 2026. Last year we had an amazing convention in New Jersey, and this year we're bringing the same energy but 2x the attendance to the Bay Area from October 9th to 12th. It's going to be at the Embassy Suites in Milpitas, and we're going to have an amazing programming. So I have some photos from the last convention over here. Um, but all in all, it's going to be a jam-packed event with a lot of networking opportunities. So you could get opportunity to connect with fellow healthcare professionals, a lot of workshops, a lot of panels, a lot of keynotes, and then also some amazing nighttime programming and vegan Jain food. So for those who are interested, it's going to be amazing, delicious food as well. All happening from October 9th to 12th. This year, we're going to expect 300 people to attend this convention and a lot of excitement around it. So, if you're interested in registering, if you haven't registered yet, would highly recommend go to yjpconvention.org and register for the convention. And if you have any questions, feel free to email us, anyone from the directors team. And even if you're not able to join, would highly recommend donating. I'll send the donation link. This will help make the convention a success and also empower young gens, the youth, as they navigate their careers and professional journeys. So thank you. And one thing I would like to share that's related to this talk today is one of the special events that we host at this convention is our Shark Tank competition. So we actually host a Shark Tank style competition where we give an opportunity to our attendees to actually present their idea in front of a panel, to get their idea validated, to seek mentorship if they have an idea around a startup. So last year we had around 14 attendees present their ideas and win cash prizes and get mentorship. And this year we're expecting a much bigger scale now that we're in the Bay Area this year. So highly recommend joining. And yeah, feel free to have message any of us if you have any questions.
And thank you so much, Ronak. And I think one interesting thing is that the theme of the convention kind of ties in with the theme that was there for this panel, because the theme for the convention is reinventing your own wheel. And I think each of the panelists here kind of invented their own wheel, right? And went along the pathways that you did. So I think it's just super interesting and it kind of ties in really well. To wrap up, I feel like there's a lot of demand for this question. If you could do one thing to magically fix something in healthcare in the US today, what would you do? And that can be kind of our tie, our wrap up. And if you want to give any closing remarks, feel free. We can go one by one. Yeah.
I answered in the comments. I definitely feel strongly that, when teleradiology first started, we had our own packs. And I had a patient who had a lumbar spine fracture while skiing in Utah. And I actually said that one of the fractures was new and two of the fractures were old, because I had a comparison. And the next day I got a call from the patient's physician who said, "How did you get a comparison study?" And I was like, "I don't know, it just showed up for me, and let me bring it up." And he's like, "The patient was in a skiing accident. He was on vacation in Utah, skiing. And the prior was from Harlem Hospital in New York City. How did you do that?" And that's what our system did. It would match medical record number. No, it would actually match patient's name and date of birth and use a matching algorithm. And we just happened to cover the hospital in Utah and the hospital in Harlem. So that was 2008. And to this day, where I live in Pittsburgh, if you get something done at UPMC and then you see your doc at Allegheny, you're not able to transfer that scan. I think that's the dumbest, most stupidest thing, because ultimately the patient should own their scans and should own, what happens to them. Instead, they're at the mercy of competing health systems that want to fight each other for profit and market share. And etc. So they, don't let these things be shared. So that's my
reminds you of Microsoft Health Vault that went and
it
got
does.
sundowned earlier. I feel like it was one of those right things, wrong time. And
It
at
was the
this time, it
right
would have
thing at the
been.
wrong time. It was the right idea, and it never should have been shut down. So.
Yeah. Right. Next, whoever wants to go. All right.
I think we live in a healthcare system that is currently, I think, one of the most disease responsive healthcare systems, and that's all throughout the country. And while it's fantastic, it can help kind of treat your acute I had a fall and this is what happened, and I had an accident here and this is what happened. I have a heart attack and what do I do? I think it does great in that. But, what we don't do so great in is talking about health before disease sets in, and really kind of talking about prevention and well care. And we really, as I think an entire healthcare system, really don't do a whole lot of that. Like how do I optimize my health before I've even developed diabetes or before I've even developed X, Y, and Z down the road? And so that kind of well care system is what we really need to incorporate into our healthcare system. And I feel so passionate about that. And part of kind of a lot of the work that I'm doing is in that space to kind of educate our medical students about how you help treat a patient before kind of any of that happens, and how we really kind of optimize a patient's entire whole health, whether it includes sleep and lifestyle factors and mood and all of the above.
Yeah.
Oh,
you're muted.
You're muted.
Sorry. So what I would say is 10 years ago, I would have answered this question really differently than I would today. So 10 years ago, I would have said we need more incentives, to change, how healthcare is paid for, and to steer behavior in a different direction. I've now lived through multiple different changes and incentives, and I actually believe what's missing most is we need to reinstill a culture, an ethical culture within the healthcare industry. So we need an ethical renewal. There's too many circumstances that you can't litigate through policy, such that we really need people who will do the right thing even when people are not looking, and even when we don't pay them for it. It's the hidden factor on the U.S. healthcare industry's balance sheet, and I would say it's gone down over the last, 2 decades or so. And so the question I would leave you all with is like, how do we be forces for good in raising the um, the ethical reserves of our industry, which I think are just significantly depleted right now. More often than not, the wrong things are going to happen to you, and no one's going to apologize to you for it. No one's going to be there to try to make it right. Many of us are people with connections and means, and we work the back doors to make things work for ourselves and our loved ones. But if you don't have those relationships, you are completely cooked in American healthcare right now. You see it, every time you actually see patients, and every time you are a patient. So I would just say the number one thing we should all be striving for right now is not better policy. It's not new payment models. It's not more startups. It's actually an ethical renewal of our industry.
Yeah. Well, thank you so much. I feel like we've covered so many different topics, and I do apologize to anyone who asked a question that, if I couldn't cover it during this discussion. But, I really want to thank all the panelists for taking their time out to really sit down with us and talk about some really, really interesting topics and about their journeys. So yeah, with that, we're gonna close this call. Thank you, everyone, and have a great evening.
And thank you, Shikha, for moderating tonight and for the
Great
invitation.
moderation.
It's great job. Thank you so much.
Oh, thank you so much. Absolutely. I'm just super excited I got to hold a healthcare event. You should ask our co-chair Manan, how long I've been hounding on us doing a healthcare event the past couple of years almost. So super excited. I think that maybe this could be a little primer to having another one soon because I feel like the topics and the discussion is endless. I feel like, yeah.
We can take it to the convention, Shikha.
Oh yeah, for sure. Absolutely. Also, we would love to have all of you join, like come to the convention at any point. Like, if you are available in that weekend of October 9th to 12th, I think it would be really great if we could connect with you more on the side and see if, you're able to either be a guest speaker or do something, I think it would be really cool.
Happy to look at calendars. Yeah.
Oh, thank you so much.
Thank you for the
Awesome.
opportunity.
Thanks so much.
Great meeting everybody.
Thank you.
Yeah.
Absolutely.
Take care.
Jai
Bye-bye.
Jinendra.
Good to see you,
Take
Samir.
care.
Hey, Jinendra.
Bye.
Bye,
See you,
everyone.
Sachin.
Yeah. Nice to meet you, Chinar.